And one of the things Jake and I like to do is engage with you all on social media. So I'm going to be posting the live stream link right here in the chat box. Feel free to go ahead and take a picture of your study schedule or your study space. And you can also just tag MedSchoolGuru, Jake, and myself. We're always wanting to connect with you all and offer ways for you all to engage with our resources. So feel free to take a picture of your study space, where you are locking in from today. We'll get started in just about 8 minutes or so and look forward to reposting your posts.
Hi, everyone. Really excited about today. Yeah, feel free to put where you're tuning in from in the chat and really excited to go over some high yield USMLE concepts with you all today.
All right, I see some people just joining. If you have not just yet, feel free to go ahead and say hello in the chat box. If you have a nice study space right now, we'd love to see it. Feel free to take a picture of your study space and tag us on Instagram. MedSchoolGuru, MedSchoolBro, HyGuru. Tonight's going to be quite the hype session, so really appreciate everybody's engagement. And we'll be starting in just a few minutes.
In the meantime, everyone, if you haven't already, head over to this link that I'm dropping in the chat here, and you can sign up for free on our MedSchoolGuru platform, and you can take our free 120. If you're studying for step 1, we have a free 120, and if you're studying for step 2, we also have a free 120. So you can sign up using that link for free and try it out for yourself. And today we're going to be going through a few questions from the platform just so you can see exactly what we've built and also go over some really high yield topics that you're going to see on test day.
All right, guys, we're going to get started in just a little bit. If you are just joining us today, welcome. We're excited to have you all here. Feel free to set up your study space so that you will be able to lock in with us for the next hour or so. We're going to be going through not only our awesome new question bank, but 10 of the highest yield concepts that show up over and over again on your NBME forum. So we're going to get started in just about 2 minutes. Feel free to share your study space on Instagram and tag us while you're at it. We're super inspired by students like you who are here to really learn in an active way. And we hope our question bank is going to be that way that you can succeed on these very stressful exams. So Jake, maybe we can give it just about 1 more minute and go ahead and get started then. Awesome. We got an international audience. It's excellent. Jake, are we ready to kick it off?
Yeah, let's do it.
All right.
Well, welcome in everyone. If you haven't already in the chat, feel free to introduce yourself. Let us know where you're from. If you have an exam date yet, where you are at in your medical journey. Dr. Demaney and I are super excited to go through an hour session today, diving into some high yield NBME topics that are bound to show up on test day. And while we do so, we're going to be pulling all these questions from our brand new platform, MedSchoolGuru, which is an interactive learning platform that contains a question bank, active recall integration, lots of fun tools like Venn diagram, AI chat assistants. And we really designed the platform to target all the pain points in a student's USMLE prep. And we're really excited to go through some of the features today just to show you how that will support you in your study. For those of you who don't know me, I'm the face of MedSchoolBro. I'm a recent MD graduate who's super passionate about medical education, and I'll be commencing residency next year. And so I'm really excited over this next year to continue building out this MedSchoolGuru roadmap alongside Dr. Demania to deliver you the best possible education platform there is.
Awesome. Thanks so much, Jake, and congratulations on your recent graduation. Super exciting. My name is Rahul. It's a pleasure meeting each and every one of you today virtually. I'm a practicing pediatric critical care physician, and similar to Jake, very passionate about helping students succeed on their USMLE exams. I have a online course called HyGuru, which many of you may know through social media and YouTube. And I am extremely excited to team up with the MedSchoolBro team and bring to you all in the comfort of your own study space, MedSchoolGuru.
I know I mentioned this in the chat already, but what we wanted to do on this platform is give you a little taste of what the platform is all about. And so, inspired by the NBME Free 120, we have created our own MedSchoolGuru Free 120 for you to complete. And so, if you go head over to the link or go to medschoolguru.com. You can sign up for free and try our free 120. So I highly suggest, if you haven't already, make sure to make an account. And after this webinar, make sure to sign up and give it a try and let us know what you think. And always tag us in your social media posts as we love to reshare all of those.
So when we created MedSchoolGuru, we were very intentional about how we want to design this to not only stand out, but help you all as the students. And so here are some things that drive us and drive the MedSchoolGuru platform. We pride ourselves on short explanations that are coupled with active recall. Think about having flashcards right next to the question explanation so that then you know what is high yield, what is testable, and it honestly just makes studying so fun. We also like to focus on building schemas and concepts rather than recalling minutia facts. Now, in our question bank, there are definitely fact-based questions similar to what you'll see on exam day, but we have a lot more critical thinking and application questions that are going to be very representative with what you will be seeing on Prometric exam day. The final 2 points here is that we focus on clinical reasoning via question-based practice. And like we will show you today, every single sentence is broken down in a high-yield, bite-sized way, kind of like having a tutor right next to you as you're reasoning through every single sentence. And all in all, this creates a very integrated, active, precision medical education experience where you can tailor your own weaknesses. Because after tutoring for the past 10 years, I've noticed that students who are very attuned with what they need to work on and they start working on those weaker topics, those students are able to incrementally increase their scores. And that's our goal for you all, is not only to incrementally increase your scores, but have this knowledge stick for residency and beyond. So what do we offer with our MedSchoolGuru question bank? Well, we focus a lot on the highest yield content and concepts. We realize that there are so many other question banks that you may want to go through. And our goal is to isolate the most frequently tested concepts on the NBME. We've made the explanations intentionally concise compared to other resources, which may have 3 to 5 dense paragraphs per item. We focus on having active recall paired with every single question. And with that, each vignette has a clinical reasoning walkthrough, not just highlighting only what is important, but actually showing you how to think. And this is your personalized AI tutor right in your study space so that then you can learn from the question. And then finally, what we do focus on is incorporating step 1 questions right next to step 2 questions and vice versa, so that then you get a 360-degree lens and are essentially preparing for both exams in parallel because they are very complementary to each other.
Thanks, Rahul. So as I mentioned at the start, our goal with this platform was to have an all-in-one platform and one-stop shop for you. So that includes a question bank like you see on screen, where not only have we gone so far to include all the elements that Dr. Domania just mentioned, but as you can see on the left-hand side, there are clinical reasoning walkthrough to help you understand principles when approaching the vignette, as we know that knowing the content for the USMLE is really half the battle. Your ability to strategically dissect vignettes and apply test-taking strategies is the other half. And so with this clinical walkthrough, we train that style of thinking and NBME logic. Not only that, but we have our active recall integration. We know that medical literature and study methods have shown that active recall is one of the best ways for long-term retention, particularly for an exam that requires a lot of content. And so what we've done is we've built an active recall into every single question, also into our library. And as you can see on screen, we've even incorporated these illness scripts so that you get bite-sized snapshots of how a presentation may look on the USMLE. And we've even gone one step further and integrated a pathophysiologic mechanism so you actually understand why the symptomatology is presenting in that way. We know that particularly with step one, they like to test the foundational science and pathophysiologic mechanisms. And oftentimes, when you're confused on topics, coming back to the kind of bare bones understanding will help you understand, even the next steps of why we might want to consider this diagnostic test or why we might want to consider this next best step in management when it comes to step two. So that's why we've really built this all in to ensure that you have, a complete learning environment, and also you can practice flashcards if you're that type of learner. And then we have a topic analysis, as I mentioned. So all of our topics across the platform are going to be tagged back to the central library that you see on screen. And so you can easily access any topic, search them in our search tab, and you'll be able to locate any questions we have in our platform on that topic, any active recall decks on that. And you can even use our AI chat assistant to dive deeper into the topic, where we have curated very particular prompts to help you understand and reason through particular topics. And then finally, one of our last or one of our favorite tools is this Venn diagram. We know that often USMLE will come down to two answer choices or two commonly confused topics. And so inspired by getting down to two answer choices and comparing two commonly confused topics, we've built a adaptive Venn diagram where you can input any two topics and we will generate you a very clean Venn diagram that's concise, as you can see on screen. And then if you do want a bit of a deeper dive into the topic, you can hover over on the left or right panels and get a full breakdown overview. So as you can see, we've really thought through the entire learning process and hope that you can use the core question bank alongside these tools to support you in your learning. So that's the overview of our platform. We are going to do a fun giveaway at the end, so do stay tuned for that. But before we do that, we are going to dive into the core part of this webinar, and that is going to be reviewing some high-yield NBME style questions from our platform. Is everyone ready to go? I'm going to start off with the questions, and then Dr. Damania, put in the chat if you guys are ready to dive into this session. Is everyone ready to go? Awesome. Does everyone see my screen as well?
Awesome.
Amazing. Well, let's begin. We have this first NBME style question. So we have a 15-year-old boy who's brought to the emergency department by his parents due to sudden onset confusion and acting strange for the past 30 minutes. Earlier today, he complained of feeling down after an argument at school and went to his room. His parents later found him diaphoretic, pale, and difficult to arouse next to an open, half-empty bottle of his nighttime medication for bedwetting. His past medical history is significant for nocturnal enuresis treated with imipramine. Okay, very, very high yield to make that a no. On arrival, he is drowsy but arousable, oriented only to person, and his vital signs are as such. His temperature is 37.2, blood pressure is 112 on 70, pulse is 96, and respirations are 8. So this vignette is set up. We have a acute onset confusion in a teenage boy with some context that he has emptied or there's a half-empty bottle of a medication that he uses for bedwetting. I already see a lot of people in the chat. You might be thinking of a drug overdose, and that's how this vignette is setting it up. If we think of imipramine, what class of antidepressant slash nocturnal enuresis medication is that? Yes, very good. Tricyclic antidepressant. Very, very good. And I know a lot of you are going to the next part, which is the most initial step in management. A lot of you guys are putting A, which is great. And you may be thinking of the ECG changes you find in TCA overdose. And I just want to first go to the physical exam findings, which will also be in line with this, because I want to remind everyone that TCAs not only are going to cause altered mental status and neurologic symptoms in a toxicity, but they can also have their anticholinergic effects, right? So you want to think of your mnemonic, hot as a hair, dry as a bone, all of those. And so we can think of why TCAs might be used in nocturnal enuresis, right? Because anticholinergic is going to cause urinary retention, and that's going to prevent bedwetting, right? And you guys are absolutely correct if you're saying A, cardiac monitoring, because we know there's some high yield ECG findings that you can appreciate on TCA toxicity. And that is this widened QRS that can progress to a sine wave pattern. And one step further, guys, what drug IV are you going to administer? Everyone in the chat box, put your answer for a TCA overdose. Very good. Very good, Gilbert and Akash, sodium bicarb. And you can see here in figure B, you can see the sine wave and widen QRS then revert back to normal sinus rhythm after an intravenous bolus of sodium bicarbonate. Really, really good. And I just wanted to show you guys this walkthrough feature, as well as we mentioned earlier in this webinar. It helps you kind of understand the reasoning and helps guide your thinking, and how each sentence kind of contributes to your line of thinking when reaching the diagnosis or understanding what the question might be asking. So you can see here that it's breaking down the vital signs, or here it's illustrating the anticholinergic findings found in TCA overdose. So these tools are here to help guide you and support your learning. And if you see here again, one thing I wanted to highlight is the active recall built in. So instead of long explanations, and we do have chart tables to break down the incorrects, you can head over to our active recall tab. And what I love about this is, as I mentioned, you can appreciate this illness script, where it kind of breaks down the vignette to everything you need to know and what you need to recognize on test day. And what I love is, and we talked about the tricyclic antidepressants and how it has, neurologic manifestations, anticholinergic, and even hypotension from alpha blockade. But you can see here that if you're trying to understand, why they get dilated pupils or flush skin or altered mental status, it's going to help give a three-step process of the pathophysiologic mechanism, so you can lock in to those mechanisms. And again, you can review the question in a active recall manner, like you see right here. Let's head on to question 2. This is a GI hepatobiliary related question. Okay, so we have a 52-year-old man with a history of alcoholic cirrhosis complicated by ascites who comes to the ED due to a 1-day worsening diffuse abdominal pain and increasing abdominal distension. He reports feeling hot and unwell and has had several loose bowel movements. His ascites had previously been well controlled on furosemide, spironolactone, lactulose, and pantoprazole. He has no history of recent travel or sick contacts. Vital signs are 38.5, so he's febrile. Blood pressure is 98/62, so hypotensive. He's tachycardic, and his respiratory rate is 18. So it looks like he's febrile, he's a bit hypotensive and tachycardic, so he might be in a bit of a shock state here. On exam, he appears uncomfortable and mildly confused, so there might be some altered mental status. Sclerolectus is present, so jaundice. The abdomen is distended with a fluid wave and shows diffuse tenderness with mild guarding, but no rebound rigidity. Bowel sounds are present. There is no focal peritoneal sign. Now we have lab values. So on paracentesis, which is a peritoneal tap, we have an appearance which is slightly cloudy. We have a neutrophil count of 650 and a gram stain that has no organism seen, but a culture is pending. So everyone in the chat, can you first put what this kind of constellation of symptoms and signs is leading you in terms of your thought process of differential? Really good. So I'm seeing lots of SBPs in the chat. He has a background of alcoholic cirrhosis. So this is likely an acute on chronic flare-up. Yep, very, very good. And we have some signs, right? Like he's febrile, sclerorectus is present. He has some altered mental status. His abdomen is distended. Yeah. Now, it's really actually high yield for you guys to know that, particularly with the peritoneal tap, a negative culture doesn't rule out SBP. And so you're still going to want to treat this prophylactically. And so that leads us to the answer choices, which is, which of the following is the most appropriate pharmacotherapy at this time? Really, really good. So I'm seeing lots of A's. And if your line of thinking is we need to give a third generation cephalosporin in this case, something like a cefotaxime or ceftriaxone, you're absolutely correct. As mentioned, when you're thinking of SBP, Look for history of cirrhosis. Look for new onset ascites, fever, abdominal pain, altered mental status. Look for on acidic tap a neutrophil count of greater than 250, even if the culture is negative. And remember that your most common culprits are going to be bugs like E. coli. It could also even be Klebsiella or strep. You're absolutely correct if you said a third generation cephalosporin is going to be your initial pharmacotherapy. And I also want to tie in some other things. So in the vignette here, we see some other medications that patients that cirrhotics will likely be on with acute complications of ascites. And that's furosemide and spironolactone to get rid of that extra fluid. And your lactulose is going to be important, particularly with the hepatic encephalopathy, right? And with lactulose, a clinical tie-in for your rotations is to ensure that the patients are titrating to about 2 to 3 bowel movements a day because that's how it's going to be excreted. So really important tie-in there. Again, USMLE loves testing SBP. They love testing hepatic encephalopathy. So look out for signs like asterixis, altered mental status, and think of your broad spectrum third generations. Think of lactulose, diuretics, and stomach acid control as well with your PPIs. So really, really good job to everyone in the chat for your answers there. And again, so I wanted to show you guys this basic science integration part for this question. So what we've done is we know that pharmacology and micro in particular are highly tested on the USMLE. And so whenever a pharm agent or microbe is mentioned in a vignette, we have ensured to include this on the question analysis tab so you can understand the mechanism of action of a drug, the common adverse effects, or from a microbiology standpoint, the characteristics and virulence of the microbe. All right, let's head on to question 3. And this is one on pulmonology and crit care. So we have a 58-year-old woman who's admitted to the ICU after developing progressive shortness of breath and hypoxemia following treatment for severe community-acquired pneumonia. She has a history of type 2 diabetes and a 30-pack-year smoking history. Despite endotracheal intubation with volume-controlled ventilation, her oxygen remains at 82% on FiO2 of 100%. Temperature is 38.6, blood pressure is 102 on 65, and pulse is 120. So febrile, slightly soft BP, and tachycardic. Physical exam shows diffuse crackles and use of accessory muscles of respiration. So they're in quite significant respiratory distress. And we have a chest radiograph shown below, which is right here. So I'll let everyone take a look at that for a second. So if you guys are looking at that kind of bilateral opacities, that classic buzzy ground glass appearance, what is everyone thinking as a differential at this stage? We also have a lab values that are going to show that they're hypoxemic. Yeah, ARDS, really, really good. And what's a key way to differentiate non-cardiogenic, right? So ARDS versus something like heart failure. It's a pressure in one of the valves. Does anyone know? One of the chambers. Very, very good. PCWP. Awesome job, guys. Now, when we think of ARDS, which is that diffuse inflammatory lung injury that's going to cause increased alveolar capillary permeability and that protein-rich edema, what principles in terms of your ventilation is going to be most effective for patients with ARDS? Think of loss of a particular coating of your alveoli that's going to cause collapse. Does anyone know? Yep. Okay, amazing. So I'm seeing surfactant. Yep, exactly. So a lot of you are putting E, which is to increase your positive end expiratory pressure. And you're absolutely correct if that's what you're saying. Now I want to show you guys this little diagram here as a reminder that at the end of expiration, your alveoli are going to tend to collapse. And what surfactant does, which is secreted by those type 2 pneumocytes, recall from your step 1, is those are going to prevent the collapse of your alveoli at the end of expiration. And so in cases like our ARDS, where you get loss of surfactant and therefore alveolar collapse, you're going to want to have adequate PEEP, which is your positive end expiratory pressure, which is something that you can turn up and down on your ventilator. As well as low tidal volume is really high yield because you don't want to cause any barotrauma. Okay, so those two principles are really highly tested, which is a low tidal volume and high PEEP to ensure that you are recruiting the necessarily alveoli and allowing for that classic shunt physiology. Is everyone happy with that concept? And just a recap over some ventilation principles is that there's the two variables that you're looking to kind of change and influence, and this is very basic in a simple kind of breakdown, but that is your PaO2 and oxygenation and your PaCO2, right, with your carbon dioxide. And the two big things that can change oxygenation is your FiO2, which we saw this patient was on 100% already. But the other thing you can do is you can have PEEP, right, which is this positive end expiratory pressure, which allows your alveoli to stay open, which decreases shunt physiology, right? So that's oxygenation from a PaCO2 standpoint. So carbon dioxide, this is all about your minute ventilation, right? Remember, your minute ventilation is going to be your rest rate times your tidal volume. So you can either increase the rest rate, right, which will therefore increase minute ventilation, or you can increase the tidal volume, right? There's two ways that you can influence PaCO2. So again, some very basic just ventilator stuff tying into ARDS, which is an exam favorite. And it seems like all of you have got that topic down pat. So we will move on to question 4. This one's a bit of a kind of screening question. So we can start off with the STEM. Which of the following is the most appropriate next step in diagnosis? So we have a 65-year-old man who comes into the clinic for a routine visit. He has hypertension and a 35-pack year smoking history, but quit 5 years ago. His older brother died suddenly at age 70 from a burst artery in his abdomen. The patient has no abdominal pain, back pain, or limb claudication and denies weight loss or fevers. Medications include lisinopril and atorvastatin. Blood pressure is 140 on 85 and pulse is 76. On exam, there's a soft systolic bruit over the mid-epigastrium and a palpable pulsatile mass just above the umbilicus, is estimated to be about 3 centimeters in diameter. The abdomen is otherwise non-tender and there are no signs of limb ischemia. Which of the following is the most appropriate next step in diagnosis? So, what does everyone think here? So we have a kind of outpatient style question here. Yeah, you guys are all really, really good with finding the AAA signs here, right? The soft systolic bruit over the mid-epigastrium, that pulsatile mass. Now, what is going to be your first line screening for AAA? Remember, this is a one-time ultrasound in smokers above 65. Yes. Lots of you are some of you are saying A, some of you are putting C. So the correct answer here is actually C. So according to the USPSTF guidelines, on an outpatient setting like this, you're first going to use an ultrasound, a duplex ultrasound of the abdomen as a first line screening tool. And then of course, if surgery is necessary, then you're going to need to do CT angios, et cetera, to do some surgical planning. What I wanted to do here is show you the power of this AI chat because the USPSTF guidelines are really high yield. And let's say you wanted to just do a quick refresher of the high yield one. So I'm going to say, give me all of the high yield USPSTF screening guidelines I need to know for exam day. I just want to show you guys the power of our AI tutor who can help support you. So look at this here. It's going to break down all the high yield screenings, and the USMLE does like testing these. I do remember even one of these on my step 2 exam. So for AAA, as mentioned, we have a one-time abdominal ultrasound for men aged 65 to 75 who have ever smoked. Really good. Breast cancer screening here, mammography every 2 years for women aged 50 to 74. There's individualized decision for those younger than 50. And we're just going to do a quick rapid review here for everyone. Women aged 21 to 29 for cervical screening is a pap smear every 3 years. And then from 30 to 65, you can do a pap smear or a co-test with HPV every 5 years. Colorectal is going to start at 50 to 75. Some actually have now started at 45. So look out for that, which is a colonoscopy every 10 years, annual FIT or sigmoidoscopy every 5 years. Remember that it's going to be at 10 years before a first relative or 40, whichever age comes first as well. That's a high yield one to know. Lung cancer is going to be an annual low dose CT for adults age 50 to 80 with a 20-pack year smoking history who currently smoke or quit within the past 15 years. And then you can see the rest here. Now, particularly for AAA, other things that they like testing is when to operate. That's if they're symptomatic. So if there's pain, tenderness, if there's an embolic phenomena, or if they're asymptomatic and it's greater than 5.5 centimeters in males, you want to do an elective repair, or if it's growing at a fast rate. Okay. Those are typically typically 0.5 centimeters in 6 months or greater than a centimeter a year is usually another red flag for which you want to operate. Yeah, Akash, that's the mass size. And I can all of this stuff is also found in my my internal medicine guide if you guys are interested as well. But just want to show you guys the power of this. This is built into the latest models of the LLMs. So at the moment, GPT 5.1, and we'll always use the most updated model. It's also trained on USMLE resources like my resource, First Aid, etc. And so we really hope that this is a tool that you guys can use. And even more so, we've built in these pre-populated prompts, like this one here, to help you understand some high yield principles of what the question is testing. So you can see beautiful tables that are outputted. We keep it concise, keep it to the point, and we even have follow-up questions if you want further explanations. All right. Yes, very good, guys, for the surgery. So yeah, that's absolutely correct there. 5.5 rapid regression or symptomatic. Yep. All right, let's do this last question here, everyone. We have a 78-year-old man with a history of gout, hypertension, and osteoarthritis who presents to the ED with fatigue, decreased urine output, dysuria, and dark-colored urine for the past 2 days. Sounds like a bit of an acute kidney injury. He also reports mild fever, shortness of breath, and generalized weakness. His medications include acetaminophen, as needed for osteoarthritis, and hydrochlorothiazide for hypertension. So really important, guys, when you're thinking of acute injury, to always first think of your nephrotoxic medications, right? Because first line, a lot of questions are going to ask, you're going to want to discontinue those nephrotoxic medications, and then you're going to want to kind of isolate what type of injury it is, and then that's going to guide your management. So let's continue. On exam, his temperature is 37.9, BP is 152 on 88, and respiratory rate is 22. His pulse is 98. Mucous membranes are dry, and cardiopulmonary examination is unremarkable. Abdominal examination reveals no tenderness or distension. There's no costovertebral angle tenderness present, so kind of pointing us to away from UTI or pyelo. Lab studies. All right. So we have blood of hemoglobin of 13.2, Luke count of 9,600, and a BUN of 48. All right, immediately, guys, what are you thinking when you're approaching BUN labs and acute kidney injury? Do you guys have any ratios in mind of how you're going to classify acute kidney injury? Yeah, really good. So typically, greater than 20:1 is going to be pretty pathognomonic for exactly as you said, a prerenal AKI or a massive GI bleed, actually. So really, really good if you guys kind of pointed that out. And we see a creatinine is elevated, which is going to be in keeping with acute kidney injury from a baseline of 1. If we look at a urine analysis, we have dark color, high specific gravity, negative lukes, negative nitrates, and granular casts. Yes, also FeNA is really important. Good job, guys. What would you expect to see your FeNA, guys, in a prerenal AKI? What does everyone think? What's your FeNA in a prerenal AKI? Yeah, low. Exactly. Guys, remember that prerenal AKI, the damage is not actually in the kidney itself, but it's due to a lack of perfusion. So think of hypovolemia or shock states, right? And so because that's the case, you're actually not going to have a problem reabsorbing your urea, or you're actually going to want to reabsorb more water and then therefore urea, which is why you have an elevated BUN. FeNA, similarly, you're able to resorb sodium, so you're going to have a low fractional excreted sodium. Really good job, guys, with approaching those labs. So based on this picture of a pre-renal AKI, what's going to be the most appropriate next step in management? Is it A, discontinue acetaminophen, B, administer IV fluids, C, measure post-void residual volume, D, start oral TMPF? Yeah. I'm seeing lots of Bs. If you're saying B, you're absolutely correct. And I just wanted to show you guys something from my internal medicine guide and break down acute kidney injury here with you guys. So again, look out for that creatinine of greater than 3 times the baseline within 48 hours, and then those other signs of decreased renal perfusion, right? Oliguria, uremia, etc. The first thing you want to do is always approach a patient with a kind of ABCD approach, right? Are the patients stable? Look at their vitals, look at the end of bed, look at their volume status, their mental status. Because if they're unstable and you're thinking of kind of refractory, and you kind of initiated treatment and it's refractory, then you might need to initiate renal replacement therapy, right? Your hemodialysis. Remember your AEIOU mnemonic, right? Acidosis, electrolytes like refractory hyperkalemia, or intoxicants like salicylates. Because that's going to require, emergent CRRT. However, if they're stable, then we're going to continue to this evaluation. What did we say? We said you're going to want to cease or hold certain nephrotoxic medications. So think of your classic ones like NSAIDs, right? Or ACE inhibitors or metformin. Or the USMLE also likes testing contrast agents. And if a patient's going to need a contrast study, you can use IV fluids kind of prophylactically in those patients. So stopping nephrotoxic is going to be the immediate next action, but we didn't see any of those in the vignette. And then we look at the BUN creatinine ratio. And here we had a BUN creatinine ratio of 45. And so you guys are exactly right with thinking that we are in a pre-renal picture. And you can also look at the vignette, right? You're going to look out for decreased PO intake, diuresis, decreased perfusion like heart failure, cirrhosis, or NSAIDs like we mentioned. And then in the lab studies, we discussed how you're going to have that increased BUN creatinine ratio, your fractional excretion of sodium is going to be low, and your osmolality, your urine osmolality is actually going to be high, right? Because you don't have a problem concentrating the urine still. Okay. So as mentioned, if you look at our first line here, it's going to be IV fluids, it's going to be stopping NSAIDs and treating underlying causes. Then a quick kind of rapid review of these other intrinsic causes of AKI. You're going to think of your causes like ATN, which is acute tubular necrosis, acute interstitial nephritis, or glomerulonephritis. For post-renal causes, that's when you might consider that post-void study, right? Look out for patients with BPH. Look out for patients with an obstructive kidney stone. This is going to be something distal to the kidney, somewhere in the ureter or a bladder or prostate. And so likely here, you guys are going to want to start with that bladder scan. You can consider an ultrasound if there's hydronephrosis, and you're going to want to get that post-void residual, and then you're going to use things like a Foley catheter to relieve that obstruction, or of course surgical intervention if it's something like a stone that needs operation. So how did everyone like those 5 questions? How's everyone doing? Let me know in the chat if you guys have any questions on any of these topics. Feel free to DM me, email us, and we're happy to dive into them. Again, really excited about this platform. We're making kind of live updates every week for you guys. So we're adding questions, we're revising questions, we're bolstering certain tools. And so really excited that you guys are part of the first wave of students supporting us in this platform, and can't wait for all the rest with you guys. So I'm going to pass over now to Dr. Damania to finish up some high yield concepts. And again, feel free to message me if you guys have any questions regarding these questions.
Awesome. Thanks so much, Jake. And I am super excited to go through 5 more questions with you all. Are you all ready to go ahead and break down these questions and continue to review these high yield NBME topics? Everybody good? I see Gilbert is locked in. Anybody else? Go ahead and type in yes into the chat box. Awesome. Well, feel free to keep putting the comments and the answers in the chat box. We're going to go ahead and go into this question. So, which of the following is the most appropriate next step in management to improve his mental status? A 66-year-old man with a history of cirrhosis is brought to the emergency department due to increasing confusion and unsteady gait over the past 2 days. So this patient has cirrhosis and he has altered mental status. Putting both the liver and the brain together, you think about hyperammonemia, high ammonia. He has a long-standing history of alcohol use disorder, but stopped drinking 10 days ago. So what we notice here is that the patient has alcoholism, which may have contributed to the cirrhosis. As you can see, I'm trying to link all the data points together. He takes a multivitamin, but no other medications. And he had a previous episode of abdominal distension and told that his liver was, quote, scarred. Now, the prior episodes of abdominal distension, that's important. On examination, he is drowsy but arousable and able to follow basic commands. As you can see here, the objective is drowsy, whereas the increasing confusion is the subjective. And here's a USMLE tip I always like to coach. Whenever you see a vignette, look at the objective and try to relate it to the subjective. He has scleral icterus, indicating that he likely is going to have a cholestatic or hepatocellular issue. Distended abdomen with shifting dullness, indicating that he is going to have ascites. Bilateral lower extremity edema. When asked to extend his arms, they intermittently flap downward. Here are his vital signs. You can take a look. And so which of the following is most appropriate next step to improve his mental status? I want everybody to go ahead and type it into the chat. Is it to administer broad spectrum antibiotics, administer IV thiamine, begin oral lactulose therapy, or D, initiate benzodiazepine taper? Excellent. If you are saying answer choice C, you're absolutely correct. I just want to integrate a core mechanism here, and that is, remember that lactulose is going to take ammonia and it is going to turn it into ammonium. And that's because the colonic mucosa and bacteria are going to release that proton, and you're going to have ammonium, which is going to be much more excretable. Now, answer choice D, I just want to emphasize right here, is related to the fact that the patient has stopped drinking 10 days ago. But remember that delirium tremens usually is going to present with more upper symptoms, and that's high yield for us to know. Recall that answer choice B could be possible in a patient who has alcoholism, but you're going to be thinking of your Wernicke's, confusion, ataxia, and ophthalmoplegia. And in this case, the focal finding was going to be the asterixis. All right, so I know I was walking you through that question, but what I want to do is also highlight, similar to how Jake did, highlight that these same explanations that I was giving you are embedded right in our question bank. For example, the flap downward, the flapping or asterixis, is indicative of hepatic encephalopathy and supports elevated ammonia levels. As you can see here, you are going to be coached on how to think so that then you can incorporate higher levels of reasoning on exam day. All right. I'm going to push you all with the step one beyond question. Which of the following best describes the mechanism by which lactulose improves this patient's symptoms? Go ahead, guys, and take a look at the answer choices. Put your answer into the chat box. What do you think is going to be the right answer here? Step one question right in front of you. Exactly. Promotes the conversion of ammonia to ammonium in the colon. I hope you all were listening. Let's go ahead and go into the next question. This one is an ethics-based question, guys, and these are showing up very much on exam day, and that's why we have dedicated over 100 questions to just ethics to build that muscle for you. Which of the following is the most appropriate next response? A 16-year-old boy is brought to the clinic by his mother for evaluation of behavioral changes. She says that he has become more withdrawn over the past 3 months and recently dropped out of extracurricular activities. She suspects he may be using drugs, but says he refuses to speak with her about it. The patient has no known medical conditions and takes no medications. During the visit, he is quiet but cooperative. Physical exam and vital signs are normal. Mental status shows an irritable mood with restricted affect. After the physician steps out of the room, the mother requests that a urine drug test be ordered without his son's knowledge, explaining that she wants it framed as, quote, routine lab work. Which of the following is the most appropriate next step by the physician? Go ahead and type into the chat what you think the answer is. Agree to order the test and withhold its purpose? Order the test but inform the patient afterwards? Decline the request, explaining that such deception breaches medical ethics? Reassure the mother that the information will remain confidential regardless of the test result? And refer the patient for mandatory drug testing. All right, I want everybody to answer here. And if you are saying answer choice C, decline the request, you're absolutely correct. Remember that the goal, whenever you're thinking of questions related to patient, physician, ethical scenarios, you always want to establish the therapeutic or preserve the therapeutic bond. And so that's where, even if you have an adolescent or a minor, you have the duty to protect that therapeutic alliance. And remember that only if the patient was suicidal or homicidal do you have a duty to report and at times involuntarily hospitalize. But in this case, when it comes to even drugs of abuse, you have to not focus on the mom, but rather the adolescent patient. All right. Let's go ahead and go into this next question. I deliberately chose it for my specialty, which is pediatrics. So let's go through this question. Which of the following laboratory studies is most likely to be abnormal in this patient? A 5-year-old girl is brought to the emergency department by her parents after she had a seizure at home. Her parents report that she's been irritable for the past 2 days and had a low-grade fever, so maybe some prodrome here. She has no known past medical history and was adopted and has limited medical records. On exam, she is almost febrile. She is a bit tachycardic. Respirations are okay, and blood pressure is relatively preserved. Facial features include low-set ears, hypertelorism, and a small jaw. A soft systolic murmur is heard at the left upper sternal border. Schwastic and Trousseau sign are present. An EKG shows a prolonged QT interval. Which of the following laboratory studies is most likely to be abnormal? TSH, creatinine, calcium, hematocrit, leukocyte, or erythrocyte sedimentation rate? What do you think is the best answer here? And guys, bonus points if you can guess what syndrome does this patient have. Bonus points if you can guess what syndrome this patient has. Awesome. Chiranjeev, Dilma, Saul, Islam, Akash, you're absolutely correct. 22q11. And remember that the heart lesion associated is usually going to be tetralogy of Fallot. Remember that DiGeorge syndrome is a failure of the third and fourth pharyngeal pouches, and that those pharyngeal pouches normally in embryology are going to give rise to your parathyroids as well as your thymus. So let's say that I really wanted to break down this first sentence, seizures in a 5-year-old girl. Well, one thing that I can do is in this chat box, because I want to expand my knowledge on pediatric seizures, here is a suggested prompt that we put in. Break down the chief complaint into a differential and look at what you get in a very logical manner. The first is you end up getting a little bit of like a differential and NBME buzzwords associated. So in this situation, the seizures are due to hypocalcemia, and that is correlated not only with the electricity issues in the brain, but electricity issues here on the EKG with the prolonged QT. So here, what we notice is a just step-by-step clinical reasoning on how do you approach this chief complaint so you play offense and get to the right answer very early on. All right, guys. 2 more questions, and then we're going to open it up for the Q&A. Are you all having fun? Go ahead and type in yes into the chat box. I was on shift today in the PICU as the attending, and I was so looking forward to this. You all are giving me newfound energy after a very long day. So thank you all so much for your participation. Let's go ahead and go into this next question. As you can see, I like to read the last line. Which of the following is the most appropriate next step in management? A 28-year-old woman is brought to the emergency department by her roommate due to sudden onset neck stiffness and difficulty speaking. These symptoms began 3 hours after she received an IM injection of prochlorperazine for severe nausea and vomiting. She is alert and oriented, but appears anxious and distressed. Vital signs are normal. Physical exam shows forced upward deviation of the eyes and marked contraction of the neck muscles. Which of the following is the next step in management? What do you think? Diphenhydramine, naloxone, haloperidol, physostigmine, olanzapine, flumazenil. Okay, people are putting in the differential here too. So what I want to emphasize here is that this patient ended up getting a dopaminergic antagonist. So prochlorperazine is going to be a dopaminergic antagonist. Metoclopramide is another one as well. Whenever you're seeing this marked contraction of the neck and upward deviation of the eyes, you should be thinking of an acute dystonic reaction. And this can be seen whenever you have antidopaminergic medications, such as those used in the GI system, as well as antipsychotics. Now, let's understand the test-taking strategy that I talked about before, and that was always relate the subjective and the objective. As you can see here, the patient is noted to have neck stiffness, and that neck stiffness is going to be objectively related to contraction of the neck muscles. And this is kind of like the torticollis, which can be seen with acute dystonic reactions. So let's go through each of the medications. Flumazenil is a benzodiazepine antagonist. Olanzapine is going to be an antipsychotic. Physostigmine is going to be a acetylcholinesterase inhibitor. Haloperidol is going to be a dopaminergic antagonist, first generation antipsychotic. Naloxone is going to be a mu opioid antagonist. And diphenhydramine, which is the correct answer, is going to have the anticholinergic properties. It's an antihistaminergic agent, but it has anticholinergic properties. So guys, go ahead and type into the chat, what other medication could you give besides diphenhydramine that has anticholinergic properties? What's another medication that you can give for acute dystonic reactions? Excellent. If you're saying benztropine, you are absolutely correct. Remember, that is going to be an anti-muscarinic medication that will also help. Guys, Jake and I were very devious together in isolating these questions. Remember how Jake's question talked a little bit about anticholinergic? I also wanted to talk a bit about anticholinergic, but just in a different lens. I wanted to talk about it in the setting of an acute dystonic reaction. So guys, we're going to continue to do these webinars so that then we can accelerate your prep. And we've intentionally curated these questions to kind of build themes and show you some high yield test taking strategies. All right, guys, we are on our last question. Let's go ahead and go through this one. This one has a bunch of labs, and we will break down the pathophys as well. Which of the following is the most likely underlying cause of this patient's symptoms? A 17-year-old girl is brought to the clinic by her mother due to concerns about irregular menstrual cycles and facial hair over the past year. So this is going to be a chronic issue. Since menarche at age 13, she has had menses every 2 to 3 months. She's also noticed worsening acne and increased coarse hair on her chin and upper lip. So some of these are normal puberty, but others are showing that there's high testosterone. Her BMI is 25.5, so she is overweight. On exam, she has moderate acne over the jawline, chin, and coarse terminal hair on the face and lower abdomen. Pelvic exam is unremarkable. Here, we notice that the testosterone level total is a little bit elevated, but DHEAS, TSH, and prolactin are normal. So what do we think is the underlying cause of this patient's menstrual irregularities, facial hair growth, and elevated testosterone? Go ahead and type into the chat what you think the answer is. And come on, guys, I want everybody to answer. We have over 100 people here. Excellent. If you are thinking polycystic ovarian syndrome, you are absolutely correct. Let's understand the classic illness script for polycystic ovarian syndrome. I'm going to go ahead and go through this. The classic illness script for PCOS: irregular menstrual cycles and facial hair growth in a 17-year-old with elevated BMI who now presents with signs of androgen excess, such as acne, excessive hirsutism, and transvaginal ultrasound showing multiple cystic ovaries. Let's understand the pathophys. Well, irregular menstrual cycles are going to be due to the fact that you have too much androgen production, and that is going to throw off your menstrual balance. The facial hair growth, well, that's because of the high androgens. The excessive hirsutism, that is going to be, again, associated with the high amount of androgens. So what I love about this question bank is that you can test your knowledge right after going through the main analysis, which is very short. So what I like to do is I like to go into this question bank and I like to go through each of the rapid recall questions. So for PCOS, what's the initial management? Lifestyle interventions, including weight loss. Which of the following hormonal imbalances is commonly found in PCOS? Well, they have elevated testosterone levels. Go ahead and type into the chat, what type of medication can we give to reduce the downstream phenotypic effects of elevated testosterone? What medication? Hint, it's a diuretic that has anti-androgenic properties. Okay, Madhumita, Doria, Smashi, good, excellent. Spironolactone. What's a common associated metabolic condition with PCOS? Insulin resistance and type 2 diabetes. Let's integrate some derm. Remember, acanthosis nigricans. And all right, here is the last question of the day. What imaging finding is seen? And that is multiple cysts on ovarian ultrasound. And remember, your LH and FSH ratio is going to be elevated as well. And that contributes to the multiple cysts on ultrasound. So guys, we all went through the 5 highest yield concepts. Just to recap, we went through everything from DeGeorge, PCOS, sprinkled in some ethics, and also Jake's wonderful questions. And we hope you found common themes to reinforce the learning. So with that, what we're going to do is we're going to stick around for a Q&A, and we really hope that you all found value. One more thing that I'm going to do before you all log off and before we start the Q&A, I'm going to go ahead and put into the chat box the MedSchoolGuru free 120. Again, it's absolutely free to go through 120 questions with the score report. So we just genuinely want to provide you value in your journey. And feel free to go ahead and snap this webinar in your social media account and tag us. And with that, Jake, let's go ahead and do a little bit of Q&A. Oh, I think you're on mute, Jake. Sorry.
Sweet. I was just going to share the screen here. If everyone wants to get their phones out, we're going to do a quick giveaway before this Q&A. So if you want to take a picture of your study setup in the MedSchoolGuru platform on screen here and tag MedSchoolGuru MedSchoolBro and HyGuru, we will be giving away one 365-day step 2 license. So guys, take out your phones right now, snap a picture of your study setup, tag us, and we will be doing a giveaway. I also wanted to note that if you guys are interested in getting the full platform, you can use code webinar20, and I'll put that in the chat right now. So if you sign up for free through the link Rahul sent, and then use code webinar20 inside the platform when you upgrade, you'll get a special 20% off if you attended this webinar. So really excited to offer that to you guys. And with that being said, we'll do a Q&A now. Gilbert, when will surgery book be released? We're actually going to be releasing that this week, which is really exciting. So stay tuned for that. Any questions related to USMLE prep, the platform, anything, feel free to let us know in the chat, and we'll stick around for a few minutes to answer your questions.
Looks like we have some questions in the Q&A. Quick question with regards to the free 120. Is there an equivalent conversion in the same way that the NBMEs do for potential test day scores? So currently we just have Phoebe the percent correct, but as we accrue more users on the platform, we'll be able to calculate hopefully a EPC or scaled score for you. But in general, I would shoot for greater than 68% on our free 120. Bashir asks, any live CK classes? Well, I know that Jake and I are going to keep doing these pop-up webinars together. So we're going to be very excited to continue this, and we will look forward, Bashir, to seeing you there as well.
Step 2, so I see a question on the Step 2 Qbank. So currently we have about 1,200 questions for the Step 2 CK Bank. We are really, really excited. We've been working tirelessly on your shelf simulated exams of 120 questions each. So we are going to be releasing in the new year shelf exams in a simulated exam tab, which will have all, covering pediatrics, surgery, internal medicine, family medicine, etc., all the shelf exams. So that's going to add another about 1,000 questions, and you guys will all get access to any updates. So if you purchase today, use code webinar20 and get that discount. In a few months from now, when we have more features, more questions, you will automatically get access to those all.
Awesome. We have another question here, how to incorporate this with UWorld. So I think that our resource and UWorld pair very well together. I would still continue to do some form of UWorld questions during the day, but our platform is good for not only creating the Venn diagrams that you see Jake creating on screen, but in addition, I would utilize our platform for more focused or tailored review. Let's say in UWorld, you are not doing as well in pediatrics as a clerkship. You can go through our question bank with all the pediatric high yield NBME style questions, and that will hopefully bump up your full length practice exam scores as well.
Yeah, and I want to show a tool here. Gilbert, you're asking about integrated Anki. What we've actually done is we've integrated the flashcards right into the platform. So as you can see, this is the test I did today on the webinar with you guys. And when you hit view results, you're going to see all of our topics tagged, and then you can go right into the active recall session in a flashcard style manner like this. This one was on the iprapermine question that we saw with nocturnal enuresis. And then you can even see other topics that can be tested in relation to CCA overdose. So as you can see, we've integrated the active recall directly into the platform so that you can have all your study tools in one place. Yeah, so Dr. Zara, the MedSchoolGuru bundle is integrated into the MedSchoolBro bundle is integrated into the platform. So we are also working tirelessly to link all of the ebooks that you see that I've used, as well as for step 2. So at the moment, step 1, we have our step 1 ebook is going to be tagged to the question bank. So all of our diagrams that you see in our guides are going to be showing up in the explanations. We're also doing that for step 2. Our step 2 bundle is going to be released very shortly, and we're going to